Shall I start, Hari?
Yeah, please.
Good evening, friends. A very warm welcome to the final session of this physician's course, in which we have heard from global experts and learned a lot of new things. I hope you all have enjoyed this program, and hopefully, this program has helped all of us to update our knowledge in the management of our heart failure patients. So, today, after the final session, there'll be an examination. Good luck to everybody, and over to you, Hari.
Thank you, Dr. Chopra. Welcome to the final day of the physician's course. We have, I hope we had 6 days of fruitful presentations and discussions. I think this time we had a very good number of around 400 people participated almost daily. And we will have the post test today. Post test, we will have 25 questions, and you can go through the test and take it and you have to have 75% of the scoring. Then the certificate will be automatically generated. If you are not able to score, you can take the test again any number of times. The basic idea is not to test, but to drive the messages which we have tried to convey through this physician's course. Basically, to improve the guideline-directed medical therapy in heart failure, which has shown to gain 7.5 years of life to a patient with heart failure. So that is a message, and that is why we are doing such courses to give the benefit of this therapy to patients with heart failure. So with that, today we have first the recap of the previous day's session by Dr. Sajan Ahmed. Then followed by our international faculty, Dr. Anna Abreu will talk on rehabilitation in heart failure, which is not very widely practiced in India. And then we will have a session by Dr. Tiny Nair on chronic heart failure, long-term management, how to follow up, when to stop, reduce drugs, etc. Very, very important topic. Then we will have a recap and a panel discussion with all those around. So you can post your questions, and based on the questions, we will have discussions. So please post your questions so that we can have a lively discussion. So over to Dr. Sajan Ahmed for the recap of the previous session.
Yes, I hope the slide is visible.
Not yet.
Visible, sir.
Yeah, visible. Yeah.
Visible, right, sir?
Yeah, go to full screen.
Yeah.
Yeah. Okay. Yeah.
Ready. So, good evening, everyone, and it's nice to be part of the HFAI program. And of course, the learning will continue today, and I hope the recap will be useful. And best of luck to everyone for taking the examination, if you can call it that. So, the last session we had a brilliant discussion on advanced heart failure, current strategy of management by Dr. Frederick Verburg. Then we had an extensive discussion on cardiac transplantation by Dr. Sundar and a few interesting cases presented by Dr. Bhagirath and Dr. Sandeep Seth. So we'll have a quick glance at the key points. The first talk was on advanced heart failure, the current strategy of management by Dr. Frederick. And we all know about the progression of heart failure, and the important point that he stressed on was the concept of true heart failure remission, which includes 3 important components. One, restoration of systolic function, no residual congestion clinically, and no need for maintenance diuretic. So this would be an ideal situation of a heart failure remission. And as Harishnan sir has mentioned, the importance of guideline-directed medical therapy is that when you use the drugs optimally, we gain up to 7 life years for our patients. And the important factor is that the sooner we start this treatment in the natural history of heart failure, the better will be the outcome. And the more complete your treatment, the better will be the outcome. An interesting concept of pulse pressure being utilized as a cheap man's Swan-Ganz was introduced. In fact, a case scenario was presented in which a a patient with a low systolic pressure of 90 and a diastolic pressure of 70 with a pulse pressure of 20 has in fact a mean arterial pressure of 77, but this patient has got a low cardiac output. And so the concept of using vasodilators in such settings was also discussed. The device therapy is underutilized, especially in India. And Dr. Frederick stressed on the fact that the early device therapy in indicated patients would actually enable more patients to receive the optimal doses of heart failure medications. And of the device therapies, the one with the maximum impact on improvement in the systolic function is, of course, the cardiac resynchronization therapy in patients with sinus rhythm, ejection fraction of less than 35%, and a QRS duration that is wide, ideally more than 150 milliseconds, and of a left bundle branch block morphology. And this is especially important that because patients with dyssynchrony cannot be cured completely with the use of drugs alone. And these patients should be actively searched for when we manage patients with heart failure. And regarding the CRT response, he stressed the fact that almost 50% of patients who are actually candidates for CRT do not receive the therapy, and this is a big global problem. And regarding the non-responders, in some particular situations, like in genetic cardiomyopathies, non-responder status, that terminology should not be applied loosely, because even a prevention of further deterioration of LV systolic function in such genetic cardiomyopathies could be taken at least as a partial response to CRT. Regarding ICDs, of course, to prevent sudden cardiac death, those who are candidates should be encouraged, and the incidence of sudden cardiac death is actually higher in countries where the ICD adoption rates are low. Regarding slowing down of the disease progression, an extremely important component, because each decompensation leads to hospitalization and further impairs the outcome. And we have to take a more proactive approach to preventing heart failure hospitalization by intervening medically in the pre-symptomatic phase of the patient, and for which remote monitoring systems have been found to be very useful. Apart from that, what can be done practically in our situation is more dynamic diuretic treatment and up titration when required, but also down titration when the patient achieves a euvolemic status and is better decongested, so that the other medications can be given at the right doses, and also the incidence of dyselectrolytemia can be brought down by the judicious use of diuretics. Of course, in patients in whom the heart failure syndrome is contributed mainly by valvular disorders, like especially the secondary mitral regurgitation, intervention can be useful. And he concluded by mentioning that the ultimate goal should be heart failure remission with the use of the 4 pillars of therapy, and if possible, the use of pulmonary pressure monitoring to prevent congestion. Following this, there was a brief discussion, especially on the role of inotropes, and he mentioned that in his center and country, the use of inotropes have drastically come down, and they use it only when it is absolutely required. The role of levosimendan as an intermittent therapy was also discussed. Apart from, there was a question on the role of digoxin in patients with heart failure, and where he mentioned that he uses it mostly in setting of right ventricular failure or a biventricular dysfunction. After that, there was a talk on heart transplantation by Dr. T. Sundar, and he touched upon the latest International Society for Heart and Lung Transplantation guidelines in 2024, and also our own Heart Failure Association of India's 2025 guidelines on heart failure. The most important message that he gave at the onset was that transplantation should be viewed as a salvage procedure in a desperate situation, not just by the treating doctors, but also by the patient and the family, where everyone understands and agrees to the problems of immunosuppression in return for relief of symptoms, in addition to an increase in improvement in longevity. And he stressed on the importance of the heart failure team, and this I Need Help, which is an often quoted mnemonic for timely referral, where you identify patients who are potential candidates for transplant. And it doesn't mean that they all have to be referred for transplantation immediately, but we have to start the conversation with the patient and the family and list them for transplant. There are many heart failure models which are used to prognosticate, and heart transplant should be considered if 1 year survival is less than 80%. And cardiopulmonary exercise testing is extremely important for patient selection with a VO2 max of less than 10, a predicted survival of less than 80%, and a medium or high risk score. So if the VO2 max is more than 14, it may be prudent to defer listing. The crux of the issue is to identify the optimal transplant window where patients should not be too well and should not be too sick to undergo a transplant, and this is actually the challenge. Patients may require heart transplant due to multiple indications, due to varying etiologies of heart failure, and there are some absolute contraindications like a systemic illness with a reduced life expectancy, or an active malignancy, or HIV infection, or significant lung disease, or fixed pulmonary hypertension. There are other relative contraindications like severe peripheral vascular disease and symptomatic carotid stenosis which could be controlled with the use of various other therapies, and then these patients could become candidates again. Now, recently there has been a change in the approach to the transplant recipients. So the age, earlier it was 60, but now surgeons are accepting older patients. They're accepting more obese patients, even up to a BMI of 35, and cancer therapy has improved dramatically, so that many patients who had history of cancer may ultimately turn out to be recipients too. Regarding cardiac investigations, he stressed on the basic evaluation apart from the perfusion imaging and cardiac MRI, and to look for viable myocardium, which could be improved by revascularization. The most important part of the assessment is the assessment of the pulmonary vasculature, and PVR of less than 1.5 or at the max 2 would is considered to be okay. Anyway, a PVR of above 4 is considered to be a no-go area. Renal factors and hepatic factors have to be considered, and immune screening is part of the pre-transplant workup. And situation specific to India is, of course, the late presentation with heart failure and lack of awareness regarding the option of transplant, the lack of availability of donor organs, and of course, the need for more social education. Complications, of course, which were mentioned are infection, especially related to the immunosuppressive therapy, rejection, coronary artery vasculopathy, and the side effects of mandatory anti-rejection drugs, especially the increased incidence of cytomegalovirus infections and accelerated atherosclerosis. Post-op surveillance, of course, is required because doing a transplant is only half the job, and surveillance is important. Currently, the median survival is 12 years, 1 year survival is more than 90%, 5 year survival is 70%, 10 year survival is 50%, and 20 year survival is 20%. So that is the data. And he concluded by stating that cardiac transplantation remains the most successful treatment for patients with advanced heart failure, which is refractory to medical therapy. Then we had two excellent, interesting cases by Dr. Bhagirath Raghuraman. And so this was the first case of a 54-year-old lady with breathlessness, and she had an ejection fraction of 50%, mild hypokinesia of the infralateral segments, underwent a CT coronary angiogram which showed LAD and RCA disease. The MRI showed late gadolinium enhancement and multifocal areas of mid-myocardial to subepicardial enhancement. And the final impression based on the T1 and T2 mapping and the MRI sequences, whether it is an acute myopericarditis, probably granulomatous or eosinophilic myocarditis, and a differential diagnosis of Churg-Strauss syndrome was also mentioned based on the blood parameters also. The patient had a hypermetabolic pattern of mediastinal lymph nodes on PET scan, and the patient underwent PCI to the LAD and RCA for the coronary artery disease. Endomyocardial biopsy was done for this patient, which revealed findings suggestive of eosinophilic myocarditis and subendocarditis. The eosinophil percentage was a whopping 43%, and patient had a troponin, significant troponin elevation. So the diagnosis of an eosinophilic myopericarditis with a hypereosinophilic syndrome was done, and steroids as a first-line therapy was done, and patient improved, this systolic function improved. The second case was again a 37-year-old male who presented with a large pericardial effusion in cardiac tamponade. So this was a large pericardial effusion, immediately drained, And subsequently, the patient underwent cardiac MRI, which showed features of non-ischemic dilated cardiomyopathy. And there were areas of transmural enhancement in the cardiac MRI. Endomyocardial biopsy was done, which showed diagnosis of, again, eosinophilic myocarditis. For this patient, they had to undergo ECMO initially, followed by steroid, and then the patient LV function improved. So these two cases highlighted the eosinophilic myopericarditis in hypereosinophilic syndrome, which occurs with a persistent eosinophilia of more than 1,500 cells per microliter, evidence of end organ damage, cardiac, cutaneous, lung, GI, or nervous system. And cardiac involvement is seen in almost half of the patients with hypereosinophilic syndrome. The last session was on a case which was from Dr. Sandeep Seth and team, which was presented earlier at ESC 2025. A 15-year-old boy, asymptomatic till 12 years of age, presented with 3 years of history of dyspnea on exertion. The ECG interestingly showed a short PR interval with a delta wave pattern of pre-excitation, which was the clue. And the X-ray showed cardiomegaly. Patient had elevated liver enzymes, elevated NT-proBNP, and his CPK was elevated, and LDH was also elevated, and the myoglobin values were also elevated. Patient had significant left ventricular hypertrophy, mitral regurgitation. Cardiac MRI was done, and the diagnosis made was of a LAMP2 deficiency or Danon disease. Then there was a discussion on the differential diagnosis in this setting, which should be the condition to be considered included Fabry's disease, Pompe's disease, and various forms of hypertrophic cardiomyopathy. So the major features of Danon syndrome were discussed. There is a disease expression which differs by sex. That is, the HCM-like presentation is seen more in males, and DCM-like presentation is seen more in females. There is cardiac involvement with pre-excitation, and there is also neurocognitive retinopathy, hepatomegaly, elevated liver enzymes, proximal muscle weakness, and psychiatric disorder. So this should ring the alarm bells. And the 2023 ESC guidelines were also discussed, where when you have a patient with a cardiomyopathy and a short PR interval or a pre-excitation, you have to think about glycogenosis, Danon disease, PRKAG2 cardiomyopathy, and Anderson-Fabry disease, apart from mitochondrial disorders. And if there is an extreme degree of left ventricular hypertrophy, we have to think of Danon disease, glycogenosis, and cardiomyopathy. And finally, it was the table showed that one important factor was among all these conditions, the elevated liver enzymes were seen only in the Danon cardiomyopathy, and genetic testing is now available, which can make the diagnosis. So with that, we will conclude. I hope all of you had a great learning experience over the last many sessions. But what is most important is, like what Hari sir said earlier, what we learn should be put forward into our practice, and the patients should get the benefit of treatment of guideline-directed medical therapy for heart failure. Thank you very much.
Thank you, Sergeant, for that wonderful summary of the last day's talk. I think you have done a wonderful job. So we will move to the next session by Dr. Anna Abreu on cardiac rehabilitation in heart failure. So that is a very important area. I think even though it has not shown significant mortality benefit, it improves the quality of life. So that is very, very important. The quality of life is very important whenever patient satisfaction is concerned. So over to Dr. Anna. Her talk is recorded. She will play. It will be played, and she will be joining the discussion at the end. Over to the recording.
Hello, I will be talking about cardiac rehabilitation in heart failure. My name is Anna Abreu. I am cardiologist in Lisbon, University of Lisbon, and run a program of cardiac rehabilitation. I'm also president of the European Association of Preventive Cardiology. So, as you know, heart failure progression takes us to the increase of exercise intolerance, dyspnea, fatigue, bad quality of life, psychological problems, higher hospitalizations and risk of death, and also weight gain and skeletal muscle wasting. So, European Society of Cardiology guidelines on heart failure management advise for heart failure patients to perform exercise to improve exercise capacity, quality of life, and reduce heart failure hospitalization, and also advises cardiac rehabilitation program for those who are with more severe disease, frail, or have comorbidities. In these guidelines, also from the European Society of Cardiology, from sports, it says not for only those who are with severe disease, but to all stable heart failure patients, we should perform cardiac rehabilitation programs exactly for that, to reduce hospitalization, to increase exercise tolerance, and to increase quality of life. And the meta-analysis also suggests that there might be a reduction in all-cause and heart failure-specific mortality. These recommendations are not only for patients with reduced ejection fraction, they are extended to patients with preserved ejection fraction, and they also improve functional capacity and quality of life in these patients. So for cardiac rehabilitation programs, we need a multidisciplinary team: cardiologist, an exercise expert, nurses, nutritionists, psychologists and psychiatrists, social worker, and administrative, and all other specialties that we can gather inside this team. To achieve these components of cardiac rehabilitation, we will need all those professionals. We will have to do the patient assessment, the patient education, the prescription of exercise and the exercise training program, the risk factors and comorbidities management, the nutritional evaluation and intervention, specific counseling, psychosocial support, adherence to medication and monitorization, and then to have a cardiac rehabilitation report in the end for the cardiologist and do the follow-up of these patients. Starting by clinical initial assessment, of course, we need to know the etiology of heart failure, if the patient has devices or need for devices, to know the symptom severity and stability, to evaluate the cardiac risk factors and comorbidities, to know exactly what is the medication which the patient is taking and the adherence, to evaluate the contraindications to exercise, and to do a complete physical examination. If the patient has heart failure, but also has devices, cardiac devices like ICD or CRT, of course, we need to know the substract of arrhythmias, the indication for device implantation, and the intervention cut points. Also, besides the clinical direct evaluation, we need to evaluate exams, blood testing, the EKG, the echocardiogram, and exercise testing, and many times a 24 hours Holter monitoring. And if we can do the exercise testing with cardiopulmonary exercise testing, that will be better for heart failure patients. If not, it will be a standard or other functional tests. But with the exercise test, we can evaluate functional capacity, the existence of ischemia and arrhythmia. We can evaluate blood pressure and heart rate response to exercise, and we also can have prognostic indicators. So before starting exercise, we need to make sure that the individuals with heart failure are clinically stable. And before starting the program, we also need to exclude exercise contraindications, which can be temporary or definitive, like unstable cardiac disease with deterioration of heart failure symptoms, hypotension or hypertension at rest or during exercise, complex arrhythmias at rest or during exercise, myocardial ischemia despite treatment, severe, not optimal treated pulmonary disease, and not optimized treatment. And that includes the need of devices that were not implanted yet. So exercise prescription is always individually tailored. We don't have a program equal to everybody. And the aerobic exercise intensity should be prescribed by exercise tests. As I told you, by cardiopulmonary exercise tests, if possible, if not standard, and if not, which happens in elderly people or very frail people, we need to do the 6 minutes walking test. So exercise prescription is also identical among patients with heart failure and cardiac devices. However, we have certain specificities. So cardiopulmonary exercise testing, why is it so fundamental in these patients? First, many times they are beta blocked, and we know with beta blocked exercise standard with heart rate is not the best for prescription of exercise. And this CPET can make an objective functional capacity determination through VO2 peak. Also, we can have maximal aerobic capacity for prescription if we determine the percentage not only of VO2 peak, but also of VO2 thresholds. And also, CPET gives us prognostic valuation through VCO2 slope, through VO2 peak, and other parameters, and also can allow us to evaluate the effectiveness of pharmacological heart rate control. These are several exercise training modalities. We have the endurance training with the aerobic, moderate continuous training, the interval training. Then we have strength training, the inspiratory muscles training, and for several patients who are very weak, we can do the functional electrical stimulation to increase the strength of muscles. The question is how to calculate optimal training dose in heart failure. We should follow the FIT principles for prescription, which includes frequency, intensity, duration, mode, and progression. And as I told you before, based on CPET or standard exercise test with heart rate maximal or heart rate reserve, which is better. So regarding aerobic exercise, the frequency should be 3 to 5 days a week. Optimal, it should be daily. Intensity, 40 to 80% of VO2 peak. Duration, 20 to 60 minutes. Can be continuous or interval. And the progression should be really progressive, starting lower and continuing at least 3 to 6 months. 6 months might be ideal in heart failure patients to adjust the duration and level of exercise. And for resistance, we need to do it in alternate days. We should do 2 or 3 times a week. We should follow the Borg scale for evaluating the adaptation of the patient to the increasing exercise. 10 to 15 repetitions in at least one set of 8 to 10 different upper and lower body exercises, and also this regimen should be progressive. And adding to this aerobic and resistance or strength training, it's good to include inspiratory muscle training and also yoga, tai chi, or dance according to patients' preferences to improve motivation and to make sure they adhere to the program. So, for safety reasons, we always need to start low and go slow and for a long time, not very short. The inspiratory muscle training is important, especially in those patients who have inspiratory muscle weakness, and this should be always evaluated before. So start respiratory training at 20-30% of maximal inspiratory mouth pressure, and then adjust intensity at the end of 1 week, 10 days, to a maximum of 60%. And the training duration should be around 20 to 30 minutes a day, frequency 3-5 sessions a week, minimum 8 weeks. Of course, if the patient is very weak, we can do not 20, but starting by 10 or by 5. It should be really individualized and tailored according to patient's capacity. The exercise sessions, as I told you, ideally 3 to 5 times a week, different types of exercise, aerobic, strength, flexibility, balance, and coordination, inspiratory muscle, and always monitoring the patient and adapting intensity according to Borg scale, according to heart rate responses, and according to several problems that might occur, like arrhythmias, or ischemia, or hyper or hypotension during exercise. What happens if the patient has cardiac devices? We know that patients with the ICD, the shocks are decreased when we do exercise programs of rehabilitation. And this is really very important. We know also that in patients with cardiac resynchronizer, we can improve VO2 peak from 16% to 40%, which is more than twice the value, the baseline value. And this is also important. And this is a meta-analysis that shows the increase of peak VO2 and the increase of quality of life in patients with cardiac resynchronizers that undertake cardiac rehabilitation programs. So exercise prescription in heart failure patients with devices is identical to the one with heart failure without devices, but has specificities. So we need to be aware of the threshold of ICD defibrillation and CRT resynchronization. We don't go that our heart rate goes beyond these points. The benefits are a lot, like you can see here. I'm not going to read it, but it really reduces the shocks. It improves left ventricular ejection fraction, mental health, and many other benefits. So start always under medical supervision after 1 month of implant. We have to take care, not doing it too early, like it happens with pacemakers, because it might displace the wire. Restrict initially arm resistance training, monitor heart rate, choose the exercise modalities, and assess causes of any device intervention. Left ventricular assist devices also need cardiac rehabilitation programs. We know that it is demonstrated potential benefits and safety of cardiac rehabilitation adapted to these situations, like increasing the peak VO2. And this is also demonstrated with a study with high intensity interval training, which also showed the improvement in VO2 peak, not only the moderate continuous aerobic exercise testing. So in this case, professionals need to be familiar with exercise physiology. There are no guidelines regarding these patients. There are some recommendations regarding exercise, like static bike, leg press, but there are also contraindications like running, cross-training, abdominal exercises, and others. And the advice is regarding the patients depend on venous return. So there are the phase of warm-up and cool-down that we always do before the aerobic and resistant and other trainings are very, very important. It's also important to avoid activities with torsion of the driveline and other recommendations. So individualized assessment and prescription, as in the other cases, avoid Valsalva maneuvers, secure cannulas and drive lines, avoid trauma, monitor and supervise always, and observe patients for 15 minutes after cessation of exercise to prevent complications. Also, heart transplant patients need cardiac rehabilitation. The exercise capacity in these recipients is 50 to 60% less than somebody with the same age and from the same sex. So exercise has the advantages to reduce cardiovascular risk induced by medical therapy, immunosuppressive, and also increases physical performance. It doubles physical performance, so it goes to the same value as patients who are not transplanted. These programs also hospital readmission and improve survival of these patients. And here we have from the guidelines also on sport cardiology of ESC, some recommendations for exercise and participation in sport. Other components of cardiac rehabilitation besides exercise prescription and exercise training is risk factors, comorbidities management, and education. We know that risk factors and comorbidities need to be evaluated with lifestyle changes, medication prescription. We need to promote the motivation and adherence to do it. We need to insist in smoking cessation and send the patient to a specific consult, obesity and diabetes. Education is very important. As you can see, there are structured programs with explanation of what is cardiac disease, what is heart failure syndrome, which are risk factors, comorbidities, how to manage, and also regarding education for self-monitoring and self-care. This is a picture from one of our sessions. So, psychological and nutritional assessment intervention are also very, very important. In the psychological management, we have first the assessment of anxiety, depression, and stress, social determinants, and sleep patterns. And then the intervention includes pharmacological, behavioral techniques for risk factor control and stress management. Here you have a stress management yoga session. And the nutritional assessment and intervention evaluates the dietary patterns and individualized diet counseling. And also we have counseling for return to work, sexual activity, driving and traveling, besides the nutritional assessment and interventional. Finally, we have the evaluation of the patient after the 6 months, and then the follow-up of this patient. We need to evaluate outcomes. We need to know if the patient has improved with the program. So we evaluate the symptoms, the functional capacity, quality of life, nutritional and psychological status, risk factors and comorbidities control, and the adherence to the program, medication, and lifestyle. And finally, we have the follow-up. Patients need to be followed at least at first months of the program, and afterwards we do it yearly. And we send a report to the cardiology who is in charge of the patient. In the elderly patients, we need to be more careful. We need to do a multi-component, multi-dimensional evaluation, including the problems of frailty, the problems of cognitive status changes, sedentary behavior, and so on. And here we have also, as I told before, the evaluation of functional capacity. Many times it's done, when possible, by 6 minutes walking test. So if you want to know more about exercise prescription, we have a digital tool from the European Association of Preventive Cardiology, which is called the Expert Tool. And this is a digital tool developed by Dominic Hansen at Hasselt University, where you introduce all the characteristics of the patient, and it will take you to a program very adequate to that specific patient, according to comorbidities, to risk factors, to the severity of heart failure. Of course, you need to know about exercise. It's not only doing digital prescription. You need to understand and you need to adapt sometimes, because of course, a digital tool doesn't have it all. So I would like to finish telling you that exercise is very important in heart failure before existing heart failure as prevention, as primary prevention. When we have heart failure, we should do secondary prevention, and exercise has a lot of benefits regarding, as you saw, many parameters: prognostic, functional capacity, quality of life, and also psychological and nutritional. And also it can help us to predict the future, because if you have good functional capacity, your prognosis will be much better than if you do not have it. Exercise prescription needs to be correct, to be effective, and to safely improve the outcomes. So this is a very nice paper from Rod Taylor, who asks about the 5th pillar of heart failure management. Is it not true, or is it evidence-based pillar of care? And I would say it's really very strong evidence-based pillar of care. Please join us next year. We have our ESC Preventive Cardiology 26 in Ljubljana in April. And I would like to thank you very much for your attention and wish you a very nice course. Thank you very much.
Thank you, Dr. Anna, for that wonderful presentation on highlighting the importance of cardiac rehab. So it's open to, the session is open to questions.
Thank you very much for the opportunity and the invitation.
Thank you. So it in the recent guidelines, it is said that even the sicker patients can be given a prescription for rehabilitation. That is added in the ESC heart failure guidelines. So, so the importance of rehabilitation is becoming more and more evident. So that is.
I would like to say that there are some guidelines of the ESC regarding cardiac rehabilitation that really update a lot and expand the scope of cardiac rehabilitation. And heart failure is really, really a good target for this intervention for many reasons.
So you said about the inspiratory muscle training. So what is the instrument used for that? Do you use any?
Sorry, I didn't understand the beginning of the question. Sorry. What instrument for evaluating?
Inspiratory muscle training. So what do you use for that?
We use dynamometers for evaluating strength, and then we adapt according to the maximal strength.
Oh, inspiratory muscle, you said that breathing exercises, no? You said improve
for inspiratory muscle, yes, sorry. We use spirometers, small spirometers. We evaluate the maximal inspiratory strength, and we teach the patient how he or she can use at home. We do during the sessions. It should be done first in just a few minutes. We should not start very long, because many times people are really weak. In those who are not so weak, we can expand a little bit more, but they are really trained. They can do it themselves also.
Okay. And, when we were doing a trial on rehabilitation, especially physical activity-based rehabilitation, there was a question from the ethics committee that whether this will lead on to increase in sudden cardiac death due to arrhythmias. You mentioned that, but can you elaborate and make it clear?
Yes, the question is if it decreases the number of arrhythmias. That's what you're asking. Yes? Yeah.
No, whether it increases the chance of, because you are doing an exercise, whether it will increase the chance of having arrhythmias.
Yeah. Well, this is one of the risks of exercise is arrhythmias. Exactly. That's why we always do the exercise testing, and we evaluate if with exercise the patient has arrhythmias. If the patient has no arrhythmias during exercise, no ischemia, we are not expecting him to have those arrhythmias during the exercise training. So the best way to avoid arrhythmias in our patients is to evaluate correctly the patients before we start the exercise training program.
So do you, because CPET is not available in most of the places in India, we can do a 6-minute walk test. Is it enough to assess the arrhythmic risk?
Well, first of all, if you can do a standard exercise test, not a CPET, you can also evaluate if you have arrhythmias for maximal effort. If you do a 6 minutes walking test, it's in my country is because they cannot do standard exercise tests. So the exercise they will do during the 6 minutes without arrhythmias will be enough. They need to be monitored. We need to have the EKG, not only measuring heart rate and blood pressure. But if you are doing to somebody who has a high functional capacity and is doing a 6 minutes walking test, I think that you need to put this person really walking fast, because otherwise it will not really substitute an exercise, even a standard. I would advise, CPET is not obligatory, it's the ideal form, But if you can do standard exercise test on a bike or treadmill, that would be fine for evaluating the appearance of arrhythmias. Or if you have not the possibility, you can put a Holter monitoring and tell to the patient to walk fast and to do the usual activities, but in a fast way, in order to make sure that during the training they don't have arrhythmias. The other thing is that when you are doing the training, you are monitoring the EKG, at least in the beginning, always. So if you are doing training and if you see that that patient has complex arrhythmias, you should stop and evaluate the cause of arrhythmias, if it is ionic problem, anemia, or if it is ischemia or any other problem.
Dr. Anna, can I ask a question?
Yes, sure, please.
So I'm Dr. Abraham Ullman. And what about incorporating yoga in cardiac rehab? And what is the scientific evidence there? Because many of the things which was mentioned are part of yoga. So that is first question. Second is about cardiac rehab in patients listed for transplant. How do you go about that? Because there will be a waiting list of 6 months to 1 year. And how do you approach such patients? So one simple about yoga, one complex about pre-listed patients for transplant.
Yes, thank you very much. I will start by the second question, if you don't mind. We try to do cardiac rehabilitation to heart failure patients who are waiting in a waiting list of transplant. And I have the story of a very successful case of a 40-year-old man who had a son. He could not take the son to school. He was on optimal therapy. He had the comorbidities controlled, but he could not walk. He was really, he had a great intolerance to effort, to exercise. So we put him on a program of rehabilitation in a slow going, slow starting, low dose intensity. And after 5 months, the man was going to school, getting his son, and he wrote us a very nice letter saying that we helped him so much. And after all, he was taken out from the list of transplant because he had no more the characteristics for doing transplant. So I think it's really important to start pre-transplant. Even if the patient goes to transplant, he will go in a better shape. And then it is ideal to continue the program after the transplantation. Regarding the yoga, we do yoga to many of our patients. We have an abstract on the EAPC with patients, with coronary patients and heart failure patients, not only coronary, who did yoga, and they improved very much quality of life and mental status. So the idea is not using yoga to substitute, is using yoga to add to a conventional cardiac rehabilitation program. Also for women, we are doing dance program, also included in the cardiac rehabilitation conventional program.
Okay, there is a question in the chat box. Please update on the rehabilitation in India. So rehabilitation in India, as I said in the beginning, it is not universally practiced, but I think we should start practicing, initiating a program. Initially, it should be supervised. Simple exercises like single stepping, just stretching exercises, very, very simple exercises can be given in a supervised manner in the clinic, the heart failure clinic itself, and then they can you can follow it up at home by giving videos or whatever. We have done a trial and it showed that it significantly improves. We are going to publish it. It significantly improves the hard outcomes that we are going to publish it. So I think it works in India. I think we should encourage patients to have, as you said, the arrhythmias actually comes down in rehab. That is what the data. So, so we have to initiate rehabilitation in a very, very monitored and graded fashion. So that is the thing.
For people living in distant areas, there are a lot of web-based programs also.
Yeah.
And that has got a wider reach because not everybody would be able to come to the clinics very frequently, especially in a setup like ours.
Yeah, I agree completely. One of the problems of underutilization of cardiac rehabilitation is that patients live far away from the centers. So when we had the COVID, we decided to create an online program so patients can see the exercise specialists doing exercise. They can be followed at distance. We can look at the patients and they can look at us. We can correct the patients. They are educated regarding self-monitoring heart rate. Many of them can also monitor blood pressure. So what we do is we do a first education on site, and then they go home and they can do it at home, many times supervised by us at distance. And they are educated if they feel any symptoms or anything, they need to stop and they need to tell us. So we are doing this program not for severe patients. We are doing this program for low or intermediate risk for exercise. We are not doing for severe risk because those patients, we need to have it in the hospital or in the clinics and to make sure they don't have any problems. But what I know is from the regular cardiac rehabilitation programs with good assessment of the patients and good supervision and monitorization, the percentage of severe, of major events is very, very, very low.
Okay, thank you, Dr. Anna, for that wonderful discussion. Because
Hari, can I put in one word about in India?
Please.
So we have an SOP in our institution on cardiac rehab, and recently Tamil Nadu government trying to collaborate, and hopefully Tamil Nadu government will take cardiac rehab, and this does not include CPET, and to all the government hospitals in the state, and that's a wonderful step forward, because if that can be implemented across the state from primary health centers to medical colleges, that would be a wonderful step forward.
Yes.
That's nice.
Very nice.
Thank you, Dr. Anna. I think we would like to continue the discussion, but because of the time constraints, thank you so much for joining.
Thank you very much. Thank you very much for the opportunity and for this invitation, and congratulations for this very important course. Thank you.
Thank you. Now we will move on to the next presentation by Dr. Tiny Nair. So over to Dr. Tiny's presentation.
Good evening, ladies and gentlemen. Today, we would be talking about chronic heart failure. What would be the issues in long-term management? Now, we all know that today we have fantastic treatment for management of heart failure, and those we call them as the Fantastic Four. The Fantastic Four, as we all know, for treatment of heart failure with reduced ejection fraction or HFrEF are four: SGLT inhibitors, ARNI, MRA, and beta blockers. Now we call them the Fantastic Four because all these four drugs individually improve survival, reduce hospitalization and worsening heart failure, reduce sudden cardiac death, and improve symptoms. Because they do all these four, they form what we call as the pillars of heart failure treatment. So whether a patient is symptomatic or asymptomatic, mild, moderate, severe heart failure, whatever be the etiology, these 4 agents need to be there on board unless there is an absolute contraindication. Okay, that's very clear. We know that these agents, when given together, they give us a fantastic benefit in heart failure. A very clear, better outcome. But the question is, what about the long-term outcome? We tried to find that answer in our Trivandrum Heart Failure Registry. As all of you know, Trivandrum Heart Failure Registry was among our friends, which ran in this city of Trivandrum, pioneered and conceptualized and done by Professor Harikrishnan, where we all joined and looked at patient data of about 1,200 patients, fairly meticulously followed up for a long period of time. Now, the first data came out in 2015 in American Heart Journal. Subsequently, we got it published in almost every top journal in the world. We learned that 50% mortality at 5 years. So when we analyzed the 5 years data, we were kind of surprised that there's 50% mortality at 5 years. We have just finished analyzing the 10-year data, yet to be published, but that data is even more horrifying. 82%, 83% mortality at 10 years. So the long-term data of follow-up of heart failure, ref, in our own state looks dismal and bad. Now, the Trivandrum Heart Failure Registry taught us a lot of things. But I think this is something that need to be reminded to us in every meeting, and that is here. If we look into the timeline in the x-axis, days of 20, 40, 60, 80 days, not long-term, but days, and look at the cumulative mortality data. In the y-axis, we see that those patients who received guideline-directed medical therapy, GDMT, did extremely well. While those who did not receive guideline-directed medical therapy, on top blue line, did worse. How bad? Actually, they had 3 times higher mortality. 3 times higher mortality, right? So they did really, really bad. But then what was painful was only 24% of our patients in Trivandrum Heart Failure Registry received GDMT, while 75% didn't. 76% didn't. Now, when we are talking about GDMT, we're not talking about fancy ARNI or SGLT here. During those days when we started the Trivandrum Heart Failure Registry, the GDMT meant ACE inhibitors, beta blockers, and aldosterone antagonists. And that is where we started from. Just the basic 3. RAS inhibitors, beta blockers, and MRAs. Now, today we have the 10-year data, which clearly indicates that those patients who were given GDMT at discharge had a survival benefit at 10 years. And I think this is a fantastic outcome data that gives us a long-term decision-making power on a disease like heart failure. Right. In fact, if you look into the 5-year data, there's a 5-year published data of Trivandrum Heart Failure Registry. Look at the data. If you look at discharge beta blocker, the odds ratio is 0.55, which means if the doctor at discharge of a patient of heart failure had written a prescription of beta blocker, 5 years later, that translated to a reduced mortality by 45%. Isn't that fascinating? A discharge prescription of beta blocker 5 years later gave us an edge of mortality reduction of 45% just with beta blockers. And that is why we need to look into long-term data. Now, one of the standard long-term data that is always quoted is this data. Heart failure with preserved borderline and reduced ejection fraction, the 5-year outcome. This came in 2017 in JACC. We are all aware about it. It showed that if you look into the spread of heart failure, HFpEF in gray, HFrEF in blue, we see that they're almost kind of equal, right? 45, 45. Okay, HFpEF and HFrEF. And if we look into the long-term outcome, when they looked into the long-term 5-year mortality, long-term data, clearly the lines overlap. So HFpEF behaved as bad as HFrEF. And in fact, we have quite some data which reminds us that HFpEF might have a worse outcome, depending on the comorbidities they have. But basically, this 5-year data showed they overlap and they're almost similar at the end of 5 years. So HFpEF or HFrEF have a bad outcome. Okay. Now, if we look into, this is very interesting, two very interesting data came out in the recent past, and we will talk about it because they're absolutely new and fascinating. The first came in 2024 that talks about the trajectories of kidney function. We know that kidney function is a major determinant of long-term outcome. So trajectories of kidney function in heart failure over a 15-year period. So 15-year period, trajectories of kidney function in heart failure. Okay, now this data, as you can see, 2,600 data came in 2020, published in 2024. And look at the data, look at the data. That line, what you see is the progressive decline of GFR. See that line starts from 65 and ends somewhere around 40. So in a span of 15 years, so that the duration is 15 years in the x-axis, and y-axis you have the eGFR. The eGFR declined from about 65 to 40, which translates to about 1.7 per year. Right. Now, what determined this slope? The main determinants are, we have just picked out the main determinant, age, presence of diabetes, and LV ejection fraction. So poorer the LV ejection fraction, presence of diabetes, and older the age, you have a worse outcome of eGFR. The slope becomes far more sharp, right? Now, the slope on an average is about 1.7 ml per minute per 1.73 meters squared per year of decline. So the GFR absolute value declines by about 1.7 per year in the presence of heart failure. And that clearly correlates with heart failure hospitalization and survival. So I think this central illustration of this article summarizes everything that we want to know, that the kidney function decline in chronic heart failure is driven by age, diabetes, LV ejection fraction, clearly correlates with heart failure hospitalization and survival. The second set of data is even more interesting. That talks about very long-term outcome of CRT, cardiac resynchronization therapy, right? The top-of-the-line device therapy in patients of ischemic and non-ischemic cardiomyopathy. So patients of cardiomyopathy, ischemic, non-ischemic, what are the long-term benefit of a device therapy? And this has never been looked into, and this is, as you see, follow-up of more than 10 years, 610 patients, and this came out right in 2025. This is this year's data. Very interesting long-term follow-up of CRTD. Now look at that. If you look at dilated cardiomyopathy patients, the 600 patients who were on CRTD, look at that. Time in years in the x-axis, 0, 5, 10, 15, and the survival probability of survival in the y-axis. So survival in y, time in x-axis. The blue line is ischemic cardiomyopathy, and the red line is non-ischemic cardiomyopathy. So blue ischemic, red non-ischemic cardiomyopathy. Now let's see, draw a line at 50. The 50% probability, the probability of survival, as we see in ischemic cardiomyopathy in blue, is about roughly 8 years. While the survival of non-ischemic is far better, with a probable survival beyond 15 years. We are talking about a 50% survival probability. So this data showed that non-ischemic dilated cardiomyopathy has a better survival, long-term survival, with CRTD compared to ischemic cardiomyopathy. Now, again, the central illustration is very interesting, and we need to spend 2 minutes on this. Same study, look at that. Patients with heart failure with reduced ejection fraction, EF less than 35, QRS with more than 120, because they were put on our device therapy. 610 patients, all were put on CRTD. Right. Now, look at that. the predictors of survival. This is interesting. We are looking at what predicted survival over a 10+ year follow-up, 10+ year data. Okay. One, as we said, non-ischemic etiology of cardiomyopathy. Second, presence of LBBB. Presence of left bundle block actually meant that by CRTD you are going to benefit. We all know that. But it was clearly shown in this long-term follow-up. Decreasing age, female gender, and a higher LV ejection fraction. So better LV ejection fraction in a lady, younger age, LBB, non-ischemic cardiomyopathy. These are the ones that in the long run are likely to clearly benefit by a CRTD. And of course, with that, three things. Absence of diabetes, CKD, and AF. So absence of type 2 diabetes, CKD 3+ stage, and AFib portrays a better prognosis. So who would benefit? Non-ischemic cardiomyopathy, LBB, young age, women, higher LVF. No diabetes, no CKD, no AFib. They are the one who benefited beyond 10 years, up to 15 years. So now we know how to choose out my patient whom I'm thinking about a device therapy. From there, let us talk about 5 minutes on drug withdrawal. I think this is extremely important. And today all of us are aware that withdrawing is dangerous. And that came first in Lancet, where we talked about withdrawal of pharmacological agents for heart failure in the TREAD-HF trial, when a small group of patients, they tried withdrawing heart failure drugs. These are patients who had absolutely improved, right? And improvement was defined as what? Number one, asymptomatic. So patients were asymptomatic. Second, their ejection fraction improved either by 10 points or came above 50. Their LV end-diastolic volumes normalized, and their NT-proBNP came below 250, normal. So NT-proBNP normal, LV volumes normalized, ejection fraction came up by 10 points or crossed 50, and they were asymptomatic. So very clearly they were fine. And in those patients, they were divided into 2 groups. One group, therapy was withdrawn. And you see, if you take 10 of those 25, you take as a percentage of 10, 1, 2, 3, 4, 40% roughly had a relapse. So 40% relapsed when therapy was withdrawn. While in the other arm, continued therapy, nobody really relapsed. But then interesting what they did was 6 months later, they put this group, the continued therapy group, into therapy withdrawal. Right? Very interesting way of studying. And again, 40% went in for relapse. So it was pretty consistent. And then because this came in, they advised everybody to restart therapy. But look at that. At 5 years, 60% patients were still relapsing. So the point is, we should not stop therapy. Because if we are saying that we'll try to stop therapy and see if they relapse and restart, still they don't go back from where we started. That's the point. So we should not try stopping or withdrawing therapy. Which does it mean that for everyone we are going to continue therapy? Yes, very clearly this was shown. This is the data. You see that event rate. Very clearly, the withdrawal group had a very high event rate. So does that mean that we are not going to do anything about it? See, if we look into philosophically, we have HFrEF here with an ejection fraction less than 40, HFrEF in red. And then we have yellow, mid-range ejection fraction. Okay, now we know that HFrEF can become mid-range can become HFrEF. And then of course we have the normal ejection fraction, HFpEF, or normal persons, which could be recovery or a HFpEF, right? And as you see the blue arrows, it can go up or go down as per the ladder. So simply a recovery does not mean that he is normalized. For recovery, to normalize, we need a myocardial recovery. But unfortunately, there are very few means which actually tell us is there a myocardial recovery. And very clearly, lack of symptoms, improvement of ejection fraction, the LV dimensions, or NT-proBNP does not clearly tell us that there's a myocardial recovery. Right? And that is where the challenge lies. So there's a very beautiful article called your heart function has normalized. What after TREND-HF? Do we say, no, TREND-HF taught us to continue? Yes, it taught us to continue. But the point is, if you look at withdrawal of therapy, this is what happened. After 1 month on an average, heart rate increased by 7.5. 2 months after withdrawal, systolic blood pressure rose by 6.5. 4 months later, ejection fraction dropped by 4% and the LV dimensions worsened. And at 6 months, the GLS was down by 2.7%. The LV matrix mass, the matrix, the collagen fibers increased by 1.7 gram per square meter. So everything worsened over time, right, as we drew. So this article, they tried to put patients into a whole single spectrum of curve and divide them into two. So the probability of myocardial improvement, they said that if you have low myocardial improvement, where you have idiopathic or high genetic risk variance, where the gene is so strong that whether you withdraw medicine or what, their outcome is bad, so don't withdraw. And on the other end of the spectrum, you have high probability of improvement. Tachycardia, myopathy. Tachycardia is gone. Myocarditis. Myocarditis has subsided. Trastuzumab cardiotoxicity. The course is over, you withdraw the drug, so the agent is gone, they might improve. And everything else, peripartum, anthracycline, alcohol-induced, rise in between. But again, there was hardly any clarity. And to answer that, we will finish with this. This is very exciting. The new data just came this month, last month, July 2025, from the European Journal of Heart Failure. We talked about heart failure improvement, remission and recovery. Is a consensus document on remission and recovery and improvement. And this is what is about long-term follow-up and drug withdrawal of heart failure. Now let us look into the data. Now this is very interesting. They have put this beautiful central diagram. Look at that. You have left ventricular ejection fraction on the y-axis. So ejection fraction on the y-axis, let's draw two lines, 40 and 50. So below 40 is HFrEF, between 40 and 50 is mid-range, above 50 is normal. Now let us open up the picture. You have the heart failure diagnosis and treatment at that point of time. Let's say heart failure was diagnosed. Okay, and let us start with HFrEF. So below 40 we have HFrEF. What can happen to HFrEF? The trajectory is interesting. 50% remains as HFrEF. 20% improved to mid-range ejection fraction between 40 and 50. And 25% became normal ejection fraction. So if we take 100 HFrEF, 50 remains same, 25 mid-range, 25 normal ejection fraction. Interesting. 50, 25, 25. Now, if you take heart failure with mid-range ejection fraction, it is different. 1/3 goes down over time and becomes HFrEF. 1/3 remains same. And 1/3 improves. So when you are looking at HFrEF, 50, 25, 25. When you're looking at mid-range ejection fraction, 33 goes down, 33 remains same, 33, 1/3 improves. And of course, when you improve, you can have remission, recovery, or relapse. And that is where the confusion lies. We're unable to find out who is going to remission, who is going to recover, and who is going to relapse. Now, to solve that out, the same consensus document has given a beautiful list. On the left, you have improvement, IMP, ejection heart failure, new term. Center, you have remission. And right green, you have recovery. So you have improvement, remission, and recovery. Just like malignancy, you have improvement, remission, and recovery. Now let us look at the points one by one. One, ejection fraction increased by echo. Improvement is just meaning you need to 10 points increase of ejection fraction. But remission means you need more than 10 points and should reach an ejection fraction of more than 50. So something going from 30 to 40 doesn't matter, need to cross 50, and for recovery also same. For recovery and remission, you need 10-point improvement and it should cross more than 50%. Right. Next comes in structural abnormality. The structural abnormality in improvement might have come down, but still remains. It has not become normal. While in remission, it is minimal. In recovery, it is normal. No evidence of cardiac disease, like in myocarditis. Everything has gone away, and the cardiac structure is normal. Look at NYHA class. Could be 1, 2, 3, 4 in improved. Just 1 and 2 in remission. And absolutely asymptomatic in recovery. Let us look at NT-proBNP. Elevated in improved, mildly elevated in remission, while absolutely normal in recovery. What about stability? Not stable, very recently stabilized, and stable for the last 12 months or more in the recovery one. And finally, drugs. Yes, we need to continue drugs, whether it is improved or remission, unless you are doing a clinical trial with proper permissions. While in recovery, it's a shared decision making. Even then, it's a shared decision making for gradual, careful withdrawal or in a setting of clinical trials. So whatever, even in recovery, we need to be extremely careful in withdrawing drugs. Where probably we should. So if we are talking about who is those who have a recovery, ejection fraction improved by 10 points and reached more than 50, normal cardiac structure, NYHA class 1, BNP is absolutely normal, persistently stable for the last more than 12 months. There you can have a shared decision making and take a decision whether to withdraw or continue drugs. But the favorite today, the evidence-based medicine is still to continue drugs. Right. So that brings us to the long-term outcome in heart failure. Unlike a short-term outcome where we are looking at the Fantastic Four or a device or acute short-term management, long-term management is different. We have the doctors and we have the patients, and both are ready to handhold. But there's a huge chain of connecting link in between, right? There are devices, there are drugs, there are nurses, heart failure specialists, and insurance, because the costs are increasing, and of course the whole system that works in the long run. So, when we are looking at a long-term benefit of heart failure therapy, we need not just look at drugs. We need to look into everything: ejection fraction, NT-proBNP, kidney function, what are the long-term benefits and problems of devices, and of course, the challenges of continuing versus withdrawing drugs. Present evidence-based medicine very clearly says that it's better to continue drugs. Reduction of dose or withdrawal should be attempted in very few select cases where you might find that they are normalized by symptoms and all the parameters that we had discussed. Thank you for your time and attention.
Thank you, Dr. Tiny, for that wonderful lecture. I think he had made it clear the need to continue the guideline-directed therapy, even if the ejection fraction has improved based on the TRADAJEP data. So now the session is open for discussion.
The number of questions maybe can be answered.
Yeah. Yeah, I saw the question. So lot of questions people have asked. Anemia correction in heart failure. So anemia, there are two things: anemia and iron deficiency. Even in patients who have normal or near normal hemoglobin, there can be iron deficiency, and iron deficiency has to be corrected by doing the serum ferritin and transferrin saturation. And it has shown to improve the quality of life, not mortality. There was a question on which agent to use, ferric carboxymaltose or ferric dextrose, sucrose. So I think anything can be given. Only thing is ferric carboxymaltose, the iron content is low, around 6%. The other one is higher, around nearly 20% or so. And ferric sucrose, you have to give for a longer duration of infusion. The other one you can have a shorter duration of infusion. Any comments, Chopra sir?
No, only approved things are fricarboxymaltose and
Maltose.
for derisomaltose. Derisomaltose is not available in India. That's what I think. And sucrose preparation, I think there's a small risk of anaphylaxis and longer duration. So even though nephrologists like it, I don't think in heart failure. Dr. Chopra sir, what's your opinion?
Maximum data is with ferric carboxymaltose. All the trials which have been done are with that. So I think if both are available, one should use the one for which the data is there. And is practically free from side effects, hardly anything.
Yeah, I think unlike the previous iron preparations, this one, the chance of anaphylaxis is very low. But you have to be careful. You have to be very careful. Second is, then some other question was there. Role of SGLT2 in heart failure with preserved ejection fraction.
Class 1.
Yeah. Chopra sir, you can.
It's a class 1 indication for today for all heart failure patients, whether it is heart failure with preserved ejection fraction, mildly reduced or reduced ejection fraction. So one should use it. There was also another question about sequential therapy or altogether. The concept of sequential therapy is not there now. One should try to start the drugs, as many drugs as possible in the hospital stay, and then quickly up titrate them. Preferably, all the 4 drugs should be on board within 2 weeks or so, and up titrated to the maximally tolerated dose or the guideline directed dose within the first 4 to 6 weeks. The reason is that the mortality is the highest in the first 6 weeks to 8 weeks, and that is the time when these drugs give the maximum benefit, both to reduce mortality and to reduce further hospitalization.
There's a question on inotropes in the chat box, levosimendan or milrinone. Actually, I know this was discussed in detail in the last session. Inotropes have not much role in patients with heart failure. In cardiogenic shock, you can try noradrenaline or milrinone or levosimendan. Each has its own limitations and uses. But in chronic heart failure, people have used levosimendan for infusions in between when they worsen. So that has shown to improve the outcomes. So there are head-to-head comparison between milrinone and dobutamine. No significant difference between the two. Any comments, Abraham?
Levosimendan is maybe a particular use in people who comes with already on beta blockers, who comes with cardiogenic shock. Second is right heart failure. We have some marginal benefits levosimendan. So this and comparatively less arrhythmic effect, because even dobutamine has significant incidence of non-sustained VT, and some studies as high as 47%. So if the patient already has had a VT or runs of couplets, triplets, etc., I would be very careful with dobutamine, and I would prefer levosimendan or NORAD in that situation.
The milrinone also can have arrhythmia. So
Arrhythmic effect, yeah.
And next question is on natriuretic peptide in the presence of CKD. CKD, we know that it increases the natriuretic peptide levels. So you have to be interpret based on the background of CKD. And obesity, it is falsely low levels. These things you should know. And hyponatremia.
Also age.
Age also, yeah. Age has different cutoffs. For example, above 55 is on cutoff. Above 75, you have to go more than 1,000 to diagnose acute heart failure. So you have to be careful. And always remember that NT-proBNP or BNP values depends on acute or chronic heart failure, whether the values are different, that you have to keep in mind. When a patient coming to OPD, it is 35 and 125. If patient comes in acute heart failure, when you are suspecting, it is 100 and 300, BNP and NT-proBNP. That values you should. RNA in heart failure with preserved ejection fraction, any role? Chopra sir.
So ARNI has been, it did the trial of Paragon, which for ARNI turned out to be negative, But then the sub-analysis subsequently revealed that in patients recently discharged after a heart failure hospitalization, females and ejection fraction up to 57%, it has a role. As the ejection fraction keeps coming down below 57%, the efficacy keeps on increasing. So that is where the role of ARNI in heart failure with preserved ejection fraction is at present.
Yeah. So there is something called a supranormal ejection fraction, where the ejection fraction is more than 60 or 65. Such patients, the therapeutic response to these drugs, even SGLT2 inhibitors, are not that great. Hyponatremia, there is a question on what to prefer, 3% sodium chloride in normal saline or tolvaptan or just fluid restriction. So hyponatremia, you have to see what is the precipitating factor. Like usually it is thiazide related mostly. Loop diuretics have less chance of developing hyponatremia. So tolvaptan can be given for short courses like 3 days or 5 days, which usually improves. And if it is very significantly low levels, then you can consider 3% sodium chloride, etc. So any comments?
Also, with tolvaptan, be careful about using large dose of diuretics because you
Yeah.
know they can have a brisk diuresis and they go into dehydration. The other thing is one should not aim for a very, very rapid correction because it has got complications for the brain.
Target doses of all drugs, I think.
Can read from the book.
I think we have already given it. Is already we have in the previous sessions you can go through.
Which SGLT2 inhibitor is better, DAPA or AMPA? There's no heterogeneity in their effect. Both are equally good. You can use any of them.
How to manage SGLT2 inhibitor related UTI in female or old age patient? So I think probably because SGLT2 inhibitors leading to what is it, glycosuria, that is a mechanism of action. People can be are prone for developing urinary tract infection, especially fungal infections. So you have to advise the patient regarding genital hygiene. And if the patient has a UTI, you have to stop the drug and then treat it. And you can advise the genital hygiene and you can try restarting it. But if it recurs again, then you have to be careful on starting it.
And one comment here that so mycotic genital infections are more common rather than UTI. If the UTI occurs, if it's especially a complex UTI, having septicemia, needing hospitalizations, maybe even IV antibiotics, look for obstructive uropathy. We have picked up like from prostate ureter to strictures. So that should be like a warning sign. So if the patient develops complex UTIs, not a common thing is genital fungal infections. So these have to be differentiated. And combining with DPP4, in some studies have shown that it might be reduced. The genital fungal infection may be reduced. And if you have a non-complex UTI, generally when you reintroduce, it does not recur because we are more careful there. So these are the points about UTI and genital infections.
Abraham, you might also answer GDMT changes how to guide when heart failure patient develops renal dysfunction or decline in renal functions.
Okay, so this is a very important thing. So as per, I will make it very simple. Incorporating what is said by ESCS. So the cutoff for doubling, if the creatinine doubles, be very careful. Potassium goes more than 5.5, be very careful. And if the creatinine goes up more than 2.5, be very careful. But actual cutoff may be up to 3.5. So up to 2.5 creatinine, you can continue to give or increase the dose. But more than 3.5 it occurs, then creatinine goes, or if the creatinine goes up more than 100%. This is as per the guidelines of the heart failure guidelines. But the importance is look for precipitating factors, do not panic, and have a relook. That's what and the key to me is urine output and potassium. The urine output is reasonable and potassium is okay. Then I would not be too worried till the creatinine doubles, or even maybe it goes up to more than 3.5 milligram percent.
The
Another-
point is that even if the patient develops some renal dysfunction, on long term, it has shown to benefit and it
Yes.
improves the outcome. So that is very important. Even if there's some mild increase in creatinine and all, don't panic at all. These patients actually benefit. Even if, as Dr. Abraham has said, even if it goes to it doubles or come to 2.5 and all, don't bother about that. We monitor the renal function, monitor the urine output and the potassium. If it is okay, you can continue. And long term, these patients actually benefits. And always try to give these drugs rather than completely stopping it. Try to reduce it and see whether how the patient tolerates. So it is very important. That is a very important drug to give ARNI or ACE inhibitor or ARB. So it benefits the patient. So try to give the benefit of the therapy rather than being having a fear about a mild increase in creatinine. So that is very, very important.
We
Then
also saw this in SGLT2 inhibitor trials that initially there's a dip in GFR. So when you start this in the first few days or weeks, there may be a dip in GFR with rise in creatinine. Again, as both have mentioned, don't panic. That shows that the drug is acting, because on a long-term basis, the renal preservation is much better with these drugs.
So a question about carvedilol or bisoprolol, or what is it? Some is carvedilol or bisoprolol. So the point is that you should give a beta blocker which is approved. So carvedilol or metoprolol or bisoprolol is okay, but give a beta blocker. That is more important. Doesn't matter whether you are giving which agent. And try to bring to the desired heart rate between 50 and 60. That is your aim. So try to give any beta blocker and try to bring to the desired heart rate. That should be your target.
One
The
comment
drop-
here. Oh, sorry, you can.
The drop in pressure is a little bit more with carvedilol because it has got alpha blocker action also. So when it is a borderline blood pressure and you want to use beta blocker, maybe metoprolol or bisoprolol especially may be more useful.
Exactly, this is the point I wanted to make. The borderline blood pressure, bisoprolol; high blood pressure, carvedilol; and metabolically neutral, bisoprolol. Easier to uptitrate to the target dose of 10, bisoprolol. So these are the things which should make you take the decisions.
So you should remember that the target dose of metoprolol is 200 milligram OD. The long-acting preparation only you should use. The short-acting preparations are not been shown to be beneficial. Metoprolol tartrate. Metoprolol succinase is the one, the long-acting one you have to use. The 200 milligram is the target dose. Carvedilol 25 milligram BD, and the other two are 10 milligram daily. So this is the one. Pindrenone in heart failure less than 40. Abraham.
Yeah, currently there is no trial data. Some trials are going on. So I would restrict Finerenone to as a heart failure medication to ejection fraction more than 40%. But suppose he has got diabetes and proteinuria, significant diabetic proteinuria, and the EF is less than 40, I might try to use it for that indication rather than a heart failure indication. Another thing is that if a person cannot tolerate other MRAs due to recurrent hyperkalemia, I may try again off-label.
How frequently echo should be repeated in stable patients with heart failure with preserved ejection fraction who are doing well? Chopra sir, you want to answer that?
It all depends upon how good the EF is. You know, if everything is going well, a person is got a normal ejection fraction, then once in 6 months or even once a year is fine.
Yeah, if the EF is low and there is a clinical,
Then-
you go with the clinical status. If there is a patient is still symptomatic, patient is having signs and symptoms of heart failure, then more frequently echo is required. But if the patient is stable, as initially Dr. Tiny discussed, more than 50% EF in the previous echo, absolute same symptom status, probably you can space the echo yearly or in 6 months. Any other questions? What about Nebivolol? Nebivolol arformoterol is recommended in the European Society guidelines because it's just a vasodilator action also, nitrate related. So it is recommended by the ESC, but not by the American group. So it can also be tried. Not much data as carvedilol and metoprolol.
I think we can go on to the question. Otherwise, people will start leaving.
Yeah. And questions will be given in the.
Examination.
It will be given in the. It will not be shown here. It will be given in the app, so they can directly go and take it. So it will be available for the next 2 weeks. At what intervals we can uptitrate ACE and ARNI. So now the recommendation is to start the guideline directed therapy in the hospital. Admission itself is possible, and every 2 weeks you can uptitrate more than one drug. That is what it is said. So mostly, you will be starting on spironolactone or eplerenone 25 milligram, dapagliflozin 10 milligram. The uptitration is basically for beta blocker and ARNI. So you can, 2 drugs can be uptitrated at the same time. So you can do it in 2 weeks. So look at 2-3 things about if you can monitor the renal function, but most importantly, the heart rate and the postural blood pressure. That is very, very important. The simple thing is to ask for postural symptoms and do a postural blood pressure check. 1 minute and 3 minutes. If there is a postural hypotension, you have to be careful. These are the 2 things you have to be careful. Any comments, sir?
There are 2 other questions. One is about mildly reduced ejection fraction, by and large to be managed like heart failure with reduced ejection fraction. Another question about omecamtiv. At present, it is not approved. There's another trial which is going on. Let's see whether something more comes out of that.
Fluid restriction guidelines in heart failure to preserve ejection. In heart failure, the fluid restriction it is only recommended in patients who are congested, who have clinical evidence of congestion, like edema or elevated JVP or crepitations. Those patients are the ones which benefit by fluid restriction. Stable patients who are walking around without any evidence of congestion, there is no evidence to say that fluid restriction benefits. So that is very important. Don't continue, ask the patient to take 1.5 liters of water for patients who are walking around, had an admission 2 years back and all. So there is no benefit in that.
There's a question about N-acetylcysteine and diabetic nephropathy. There is no trial data. People give empirically, but there is no proper data. So that is not the drug of choice. So even though it does not produce any harm, so that is all. So if you have diabetes with proteinuria, then finerenone is the key, along with SGLT inhibitors and ARBs.
At what interval can we uptitrate ACE or ARNI?
Yeah, that
Yes.
we have already
Okay.
already discussed. Then,
When to start GDMT in ICU patients admitted with cardiogenic shock?
So on the shock, I think cardiogenic shock, you have to be careful. See the blood pressure. Once the blood pressure improves to more than 90, you can start considering starting 1 by 1. And then once try to put maximum number of the 4. Try to introduce the maximum number of drugs in the admission itself. That is where the patient is in front of you. You can manipulate the hemodynamics and make the patient discharge on the maximum number of drugs. Once the patient goes get discharged, then it will be difficult. And one more thing to highlight is that the first follow-up of a patient discharged after an acute decompensation, the follow-up should be done in 7 to 10 days. Make sure that your patient is reviewed at 7 to 10 days. Very, very important, because the hemodynamic changes occurs in 7 to 10 days. If you don't see the patient and adjust the drugs or the doses, then the chances of a readmission is much, much higher. So our advice will be to have the review at 7 to 10 days after an discharge after an acute decompensation of heart failure.
One question about vericiguat. So vericiguat is basically used in worsening of heart failure. That means a person is on adequate or full doses of the guideline-directed medical therapy, as has been discussed. And despite that, if they get worsening of heart failure, then vericiguat comes in. Also, it can be used earlier also if for some due to some reasons of contraindications, you cannot use one or two of the guideline directed medical therapies. And in that case, it can be used even earlier also.
And in patients who are having a significant renal dysfunction, whom you are not able to start on RAS blockers, you can consider hydralazine nitrate. That combination can be given. No direct evidence, especially except in patients who are of the black race. We can consider that option, but you have to give it 3 times daily. It is cumbersome to give, but we have introduced in some of the patients
Yes.
with whatever benefit.
Abraham, atrial fibrillation and heart failure, can you use metoprolol IV?
That depends on the heart rate and whether it's acute atrial fibrillation. So I would be personally have moved away from IV metoprolol, and unless if the patient has it's acute heart failure, new onset atrial fibrillation, I would rather DC word, cardiovert him rather than IV metoprolol. Unless the pressures are very high, I may not give. And I would specifically look for bronchospasm. And if there is a history of bronchospasm, I will avoid that.
Okay. Maybe same AF and corpulmonal with significant bronchospasm. Diltiazem, digoxin, what would you choose?
This is a very difficult question because significant bronchospasm, I'll avoid beta blockers. Diltiazem, because it can produce fluid overload. So already corpulmonary, it was said. So again, I would use it caution. Digoxin has got contrasting data. There is some data saying that it is beneficial in patients with right heart failure and AF. Some data saying that it may not be. So my order of preference in a patients with corpulmonary and congestion or fluid overload and bronchospasm and atrial fibrillation will be digoxin low dose followed by diltiazem and try to avoid beta blockers.
Yeah, diltiazem, this non-hydropyridine calcium channel blockers have been actually not been shown to be beneficial in patients with ventricular dysfunction. So they are actually some form of contraindicated. So we have to be careful when you give that. But in situations where you want to control the heart rate, probably you have to try those things.
Okay, I think that's about it, most of it.
Yeah, I think
we'll call it a day. And
I think Vinay, can you show the PowerPoint with the instructions for the you can send your feedback about the course, please. All the participants now, currently we have around 250 participants attending currently. We have around 300 plus people joined today. So please give your feedback regarding the questions. We want some critical comments, how to improve the course rather than saying that it is a wonderful course and all. But give some critical comments so that we can improve the course next time. We will be doing 2 courses per year. So this is the 4th year we are doing such courses. So, so Vinay, can you show the slide? Yeah, this is about the instruction for the test. So this is
So you have to log into hfaicourses.graphy.com. I've also put it in the chat box and the WhatsApp group. The username will be the registered email ID, and the password is common for all, HFAI 2025. So once you log in, you will see the post-test course. You click on that, and you just have to start the quiz. So once you start, for every question, if you see on the you will have to mark for review. Do not click on submit button. You will have to click on mark for review and go to the next questions. If you don't mark for review, that question will not be evaluated. And these questions can be attempted any number of times for the next 2 weeks. So after you mark all the questions, you can give submit. You can, if you quiz, skip the question, it will show like this: how many you have answered, how many have not answered, and how many marked for reviews. it will show the count here, and then you will have to click on submit. This is for instruction for doing the test. After the test, in the same website, if you go to the dashboard, you will see the center screen like this, and there's a small button to download the certificate. And that's all. So you'll have to get more than 70% to generate the certificate. That's all from my side.
Yeah, mark for review, and you go to the, once you press the mark for review, it will go to the next question. Okay,
Yes.
so that is what. So, so for example, if you have scored only 50% of the questions, don't worry, you can take the question again, the full questions again, and you can, or then you know the answer. The answers will be shown at the end. So, Vinay, when will you, they get the answer? Once you submit, the answers will be shown, no?
Yes, yes.
So once you submit, the answers will be shown. So you can see the answers and then take the test again. This is basically to make, don't test the knowledge of the people. It is basically to make people understand the importance of guideline directed therapy and the management of heart failure. So you can take the test again and again, and you can score more than 70 and generate the certificate. So that is the idea.
Once submit, if you go to the same place, the dashboard, you will get all your results which you have marked correctly, which you have not marked correctly, and you can also see the explanation of the answer.
Vinay, can you put the link here in the chat box?
Yes, sir, I put it here.
And kindly upload today's class. It will be, all the classes are uploaded in the YouTube link. This is the link for the course. You can click on that. And otherwise, you
Or-
can go to courses at .graphy.com. Password is HFAI 2025. HFAI 2025, all small letters and 2025.
And
have any-
to your registered emails, you would have also got the login details. So that will be the registered email. If someone has two email IDs, we only will have your registered email ID. Or you can create a new account.
Yeah, there are some good comments about the course, discussions on where both doctor and patient went wrong. Same course can be done after 6 months. So these are all good suggestions. So, Vinay, can you, lectures by foreign faculty was little difficult to comprehend. Okay, we will take the feedback and provide it to the European Society of Heart Failure, ESC Heart Failure Association regarding this comment. Then, Vinay, can you give the helpline number also in case they want to have some query regarding the certificate or anything?
Yes, sir.
This is the number which is posted in the chat box: 9972735480. Foreign faculties language we can't understand. That they are all coming from different countries, not from UK. Today's lady was from Portugal. So that difficulty we expect. But these are all leaders in the field. So we agree that more case-based discussions with the commonly encountered problems rather than rare ones. Yeah, that feedback we take. So okay, so thank you everyone, and hope you all got the link to the test. And if you have any comments, so somebody is requesting to add them in the chat in the WhatsApp group. Vinay, you can add them.
Yes.
So thank you, everyone. Abraham, the final words. Dr. Chopra had to leave for some urgent thing. Abraham, your final words and we'll close.
Yeah. Thank you very much. Only thing we have to remember is Random Heart Failure Registry, 10 years mortality was more than 80%. So it is our responsibility and our job to reduce the heart failure mortality. It's very simple, 4 drugs plus some additional knowledge. So I was just remembering there's a saying, should learn, unlearn and relearn. But more than learn, unlearn and relearn, we should apply also. We hope that the knowledge we received would be applied to our patients for the patient benefit. Congratulate Dr. Harikrishnan for a wonderful, wonderful course. Thank you.
So thank you, everyone. We will have the same course sometime in another 6 months' time, probably with the support of either Heart Failure Society of America or some international group. So hope to see some of you at least in the next course. So please conduct some fellowship offline courses on heart failure. Yeah, we have programs to come. So another announcement is we are starting heart failure clinics. So I think many of you must have been, who are participating in it, have been part of those initiatives. So we'll be starting heart failure clinics. We will be having protocols and programs for running the heart failure clinic. We'll be reaching you. So that we will be announcing it soon once our the protocol and all is developed. So with that, we will close the session. So thank you, everyone. And good night from Heart Failure Association of India. And thanks once again for the ESC Heart Failure Association, European Society of Cardiology Heart Failure Association for their support for this program. And thanks to Sun Pharma for providing the unrestricted educational grant for this course and supporting it in a very, very sincere and big way. So thanks to Sun Pharma and thanks to ESC Heart Failure. And thanks to my colleagues who are part of the Heart Failure Association who prepared the talks and participated in the discussions. So thanks to my colleagues who are in Heart Failure Association. So thank you and good night.
Good night.